My name is Charl Els, and I'm a clinical professor in the Department of Psychiatry, and I'm appointed as a physician educator in the Division of Preventive Medicine at the University of Alberta. This session focuses on the occupational impact of the use of opioids. The impact on work, in particular in safety-sensitive settings, is a growing concern. Thank you to the Workers' Compensation Board of Alberta for making funding available for this project. There are no conflicts of interest to declare. The opinions expressed in this presentation reflect those of the speaker and not necessarily those of any collaborator or funding agency. This session provides a brief overview of the features of opioids and the impact on occupational capacity and the risk. And at the end of the session, participants will be equipped to briefly summarize the features of the class of substances called opioids, describe the impact on occupational risk, and thirdly, apply the current evidence to confirm that the use of opioids is not recommended in safety-sensitive settings. What are the opioids? Well, the opioids are centrally acting drugs. It's a class of drugs that produce sedation and analgesia with adverse effects that have been consistently associated with an increased risk of motor vehicle accidents. Opioids have been used therapeutically and recreationally for thousands of years. Today, the opioids can be divided into the naturally occurring, semi-synthetic, and synthetic opioids. Morphine, which is the primary psychoactive alkaloid from the poppy plant, is also the prototypical agonist at the mu-opioid receptor. Preparations encountered today include morphine, codeine, oxycodone, hydromorphone, tramadol, buprenorphine, fentanyl, and several others. Opioids, of course, bind to opioid receptors in the brain, namely the mu, delta, and kappa receptors, where they exert their analgesic, sedating, and impairing effects. In 2014, the American College of Occupational and Environmental Medicine, or AECOM, updated their treatment guidelines concerning opioids. It addresses the question of the use of opioids by those individuals conducting safety-sensitive work. A systematic review was conducted, and the search strategies identified a total of 21,000 abstracts of articles of epidemiological studies. And all these identified studies were evaluated, but only a small number, namely 12, were included in the final analysis. No epidemiological studies were identified addressing forklift driving, overhead crane operation, heavy equipment operation, or most of the other safety-sensitive positions. To guide the question of safety-sensitive work and the impact of opioids, reliance was on motor vehicle crash risk data. Well, how does this work? That meaning, how can we use motor vehicle crash risk data for application to safety-sensitive work? Well, the extrapolation of data has been used for decades to perform quantitative and occupational and environmental risk assessments. Hegman writes in the Journal of the Occupational and Environmental Medicine that, and I'm quoting, practically it's nearly impossible to obtain direct data for most safety-sensitive positions, and the cognitive and performance skills that are required for safety-sensitive positions overlap to varying degrees with those required to safely operate a vehicle. And these cognitive functions that overlap include a range of different cognitive domains, namely what's needed is unimpaired alertness, attention, concentration, reaction time, coordination, memory, multitasking, perceptual abilities, and thought processing, as well as judgment. And driving can be viewed as the single most ideal proxy for the determination of levels of impairment for other safety-sensitive duties and tasks. Hegman and co-authors further suggest that creating the expectation that empirical studies have to be conducted in each and every particular safety-sensitive setting and for every position, and that no extrapolation is allowed before we can assume that impairment caused by opioids may pose a risk, places an unreasonable and perhaps impossible burden of proof on adopting steps to ensure occupational safety. And it's on this basis that the guideline group concluded that quality evidence consistently demonstrates an increased risk of motor vehicle crashes, and is recommended as the surrogate for other safety-sensitive work tasks. The findings of the systematic review done by the ACOM group suggest that both weak and strong opioids have been consistently associated with increased risk of motor vehicle crashes in all large epidemiological studies of working-age adults sufficiently powered to detect the risk, and the estimation of the risk ranged from 29 to more than 800%. Evidence supports the notion that opioids produce cognitive impairments, perceptual deficits, and slowed reaction times, and it's been suggested that impairment associated with some short-acting opioids, or those that are used only occasionally, may be sufficiently mitigated within 8 hours of taking it, while other opioids like methadone, a truly long-acting synthetic opioid, or slow-release preparations may result in impairment persisting beyond 24 hours. Opioid-related cognitive and performance impairment may occur even in individuals who have become tolerant to the use of opioids. And this may also be the case in persons using weak opioids. Workplace or on-site testing for impairment in persons using opioids is impractical, and it's not the recommended approach. Such impairment testing by a non-medically trained co-worker or supervisor may not be sufficiently sensitive to detect occupationally relevant levels of impairment in a person who may otherwise subjectively feel fine and believe that he or she is not impaired, even though the individual is taking opioids. Occasional use of opioids, even short-acting ones, would likely result in positive drug testing, which may be indistinguishable from ongoing use of opioids. And given the variation in metabolism, impairment may simply not be predictable. The systematic review allows for the concluding statement by ACOM, namely that acute or chronic opioid use is not recommended for patients who perform safety-sensitive jobs. And these jobs include operating motor vehicles, other modes of transportation, forklift driving, overhead crane operation, heavy equipment operation, as well as tasks requiring high levels of cognitive function and judgment. In February 2016, the Railway Association of Canada followed suit by updating their rulebook for opioid use in safety-critical positions and aligned it with the ACOM guideline, essentially suggesting that ongoing use of opioids is not compatible with working in a safety-critical position. Think about this. The burden of proof that the use of potentially impairing substances under such circumstances, namely in safety-sensitive positions, and that it's not hazardous for those settings, should really fall on the makers of these products. Not surprisingly, none of the medication instructions for opioids have been stripped of warnings to avoid driving and operating machinery. We've included a list of references that you may possibly find helpful. We look forward to your feedback and comments, and please help us identify further topics for future discussion. Thank you.